I just kind of wanted to get started to level set with kind of our listeners and our audience. Cytoreductive cystectomy, really not something that we do nowadays, right? And I think part of that is, for many years we had a certain standard of care, gemcitabine cisplatin, probably for metastatic disease. But kind of give us just a maybe 30,000 foot view of how we would really approach this whole topic and this conversation, right? Give us a little bit of the background from the metastatic setting and kind of what came about all about of this.
Yeah, well, I mean, as you and I think a lot of our listeners and viewers know, is that the responses that we saw in patients who are metastatic or locally advanced or regionally advanced in terms of bladder cancer or upper tract urothelial cancer were not great in the chemotherapy era, and it really came. I would say the whole genesis of this work arose out of a clinical dilemma that we saw when patients began having incredible responses to enfortumab vedotin and pembrolizumab,
Yeah.
and that was supported with data from the EV-302 trial. I think we started seeing these patients in clinic that had these incredible responses and either great PRs or CRs, and we didn't really know what to do with them. And we can get into this a little bit later. I think we still counsel patients in a way that we don't really know what the right thing to do in these situations are. But
Sure.
when you have a patient that has an incredible response to this new combination of drugs, surgery is on the table for them, and we offered them surgery, and that's kind of how this whole cytoreductive cystectomy or nephroureterectomy concept in this era was born.
Yeah. So I mean, just to recap, I think, and I kind of agree with you. Gemcitabine, cisplatin, and all the other kind of standard of care therapies that we had in the metastatic setting prior to EV-302 really worked, but not super great. We were not seeing a large amount of CRs for sure, right? And I think the point here is with EV-302, with enfortumab vedotin and pembrolizumab, we're seeing just at least a significant more PRs. Again, not blockbuster. We're not seeing 80% CRs or PRs, but probably much higher than we were in the gemcitabine cisplatin era, right? And that's what probably led to us at least discussing this, right? That's kind of what I'm getting from what you're telling
Yeah,
me.
spot on. Yeah.
And I would piggyback on that. And then I think, I mean, I think we're hitting the nail on the head, right? So this is a clinical dilemma that really just didn't exist
Yeah.
pre-EV Pembro, right? So even if you look at like progression-free survival, even on the EV-302 trial, right, the Kaplan-Meier curves for chemotherapy, a year after starting treatment, 80% of those patients progress, right? So when you and 90% progress within 18 months. So the idea of taking those patients to the operating room in the setting
Right.
of progressing disease, despite our best systemic therapy, is really a non-starter. Whereas when you look at the EV Pembro line on that same Kaplan-Meier curve, only half of those patients progress at a year, and it's pretty steady, like up to 50-60% out to a year and a half, right? So now you have this subset of patients that we really didn't have before, at least not at this scale, who are having great responses to systemic therapy, and they're not progressing at rates that they used to progress.
Sure. No, I think that makes a lot of sense. And I think it's a good problem to have, right? In one sense, because you're sitting here saying surgical consolidation was never really part of our, pathway when it talked about metastatic bladder cancer, and probably still would be a small pathway, but it's great to see that, we're at least seeing those patients and we don't really know what to do with them, right? I mean, that's the reality of this in the post EV, EV-302 era. So, I think when I first heard about all this, I was like, yeah, I kind of knew these patients existed, but it was very challenging to be like, who's really doing these cytoreductive cystectomy versus consolidative cystectomy? So it was great to see kind of your recent paper kind of published in European Urology, of course, correspondence to the editor, that really showed that, there's a group of patients that we can really do this for, right? So what I really wanted to know is when you see these patients, if you evaluate a patient that could be a candidate for, consolidative surgery, what criteria are you looking at? So Dan, maybe you can walk us through, kind of an evaluation of a patient you would see in clinic that you think would be a good candidate for this.
Yeah, I think the biggest thing is, well, one, surgical candidacy in general is super important.
Sure.
I also think it's important to have a really honest discussion with the patient and talk to them about what their goals are. And we can again get in to a little bit further as to what the potential benefits of doing surgery are. But if they're, having tissue and being able to analyze it and see if there's residual disease and maybe get this person off systemic therapy in a risk adapted manner is one really big advantage, we think, to operating on these patients. So if that kind of is something that's important to the patients and as well as the whole multidisciplinary team, I think that's one reason to offer them surgery. And then I think the biggest thing that's disease specific is what kind of response did they have on imaging. That's probably our best predictor. Another potential predictor is ctDNA, and I'm sure we'll talk a little bit more about that later. We did not use that in this retrospective cohort. We did not use that to guide decisions. In fact, not a ton, only about 6 patients had ctDNA, and it was used sporadically, and that's something I think we're using a lot more now. So I would say, in terms of specific to the disease, seeing in the distant metastatic sites complete resolution of the disease there, either on PET scan or conventional imaging, most oftentimes PET, or a great partial response or stability, or treating, able those lesions having the ability to be treated in an easy way. And then I think if a patient is willing to accept the risks of surgery, understanding that there may not be there's not a proven oncologic benefit, it's theoretical, and they meet those criteria and are willing to, accept the risks of surgery and they're healthy enough to do so, then I think that's kind of the big boxes for us when we've offered people these operations.
So I think that's a great point. I mean, there's no question. I think I agree with you when you say, if this patient is, fit for surgery is going to be one of the key criteria. So if you can proceed with the cystectomy, and that's probably true for really any cystectomy in general, right? So I probably in the same way.